Good morning, Dr. Phil here. Today we'll be discussing on cranial nerves 6, 7 and 8. Cranial nerve 6, the abducens nerve. Cranial nerve 6 emerges from the brainstem between the pons and the medulla. Nerve cell bodies of cranial nerve 6 lies in the pons. The motor nucleus of cranial nerve 6 lies beneath the fourth ventricle and connects with the nuclei of cranial nerve 3 and 4 through the medial longitudinal fasciculus. Cranial exit is via the superior orbital fissure. Course: cranial nerve 6 emerges from the brainstem between the pons and medulla. It traverses the pontine cistern of the subarachnoid space and straddles the basilar artery on each side. It then pierces the dura and runs the longest intradural course of all cranial nerves within the cranial cavity. Its entry point is at the dura mater, covering the clevus. It bends sharply over the crest of the petrous part of the temporal bone. It courses through the cavernous sinus, and it exits via the superior orbital fissure. Cranial nerve 6 traverses the common tendinous ring as it enters the orbit. It runs on and penetrates the medial surface of the lateral rectus. Its fibers consist of somatic motor fibers. It supplies motor supply to the lateral rectus and directs gaze laterally. To test cranial nerve 6, refer to eye movement section under cranial nerve 3. Cranial nerve 6 palsy. Signs includes inability to abduct the affected eye and diplopia worse when looking in the direction of the peritic muscle and worse for long distances than near distances. Causes of cranial nerve 6 palsy includes microvascular lesions, demyelination, infarction, raised ICP, intracranial tumors, meningeal infection, aneurysm, and inflammatory processes. Facial nerve, cranial nerve 7. Cranial nerve 7 emerges from the brainstem between the pons and medulla. Location of nerve cell bodies: for somatic motor and visceral motor presynaptic in the pons, for special sensory in the geniculate ganglion, for visceral motor postsynaptic in the pterygopalatine ganglion, for visceral motor postsynaptic in the submandibular ganglion. Nuclei: the motor nucleus of the facial nerve is located in the pons. Nuclei of the solitary tract in the medulla. Central processes of those concerned with taste sensation end in this nucleus. For the special nucleus of the trigeminal nerve, processes of those concerned with general sensations around the external ear end in this nucleus. Cranial exit is via the internal acoustic meatus, facial canal, and subsequently the stylomastoid foramen. Course of cranial nerve 7. Cranial nerve 7 fibers arise from its nucleus within the pons and leaves at the cerebello-pontine angle, with cranial nerve 8 as two divisions: the primary root or facial nerve proper, which innervates the muscles of facial expression, and the intermediate nerve, also known as nervus intermedius or cranial nerve 14. It provides sensory innervation for taste and sensory innervation of part of the outer ear, the nose, and the mouth. It provides motor supply for lacrimation, salivation, and contraction of the orbicularis oris muscle. Cranial nerve 7 then traverses the posterior cranial fossa, the internal acoustic meatus. It passes through the facial canal. It exits the stylomastoid foramen. It then traverses the parotid gland. Cranial nerve 7 runs the longest intraosseous course of any cranial nerve. Geniculum of the facial nerve. This refers to the sharp bend that occurs when cranial nerve 7 turns abruptly posteriorly to course along the medial wall of the tympanic cavity after traversing the internal acoustic meatus. This is the site of the geniculate ganglion, which is a sensory ganglion of cranial nerve 7. Cranial nerve 7 gives rise to three branches while traversing the temporal bone within the facial canal: the greater petrosal nerve, nerve to stapedius, and cauda tympani nerve. The greater petrosal nerve is also known as the large superficial petrosal nerve. It is parasympathetic and arises directly from the geniculate ganglion. It leaves the anterior surface of the petrous pyramid at the hiatus of the canal. It then continues through the foramen lacerum and enters the pterygoid canal. Subsequently, it passes to the pterygopalatine ganglion, or the sphenopalatine ganglion. Nerve to stapedius passes to the stapedius muscle. The cauda tympani nerve. This nerve branches from the facial nerve above the stylomastoid foramen. It contains gustatory fibers and presynaptic parasympathetic fibers. It passes through the tympanic cavity and petrotympanic fissure to join the lingual nerve. After emerging from the stylomastoid foramen, cranial nerve 7 gives off the posterior auricular branch. It then enters the parotid gland and forms the parotid plexus. The parotid plexus gives off 5 terminal motor branches: temporal, zygomatic, buccal, marginal mandibular, and cervical nerves. The fibers of cranial nerve 7 are mixed and consist of motor and sensory components. General distribution of cranial nerve 7 is to the derivatives of the second pharyngeal arch. Main actions of cranial nerve 7. Cranial nerve 7 provides somatic motor supply to muscles of facial expression, muscles of the scalp, occipitofrontalis, stapedius of the middle ear, stylohyoid, and posterior belly of the digastric. Cranial nerve 7 provides visceral motor supply, parasympathetic innervation of the submandibular salivary glands, sublingual salivary glands, small salivary glands on the dorsum of the tongue, lacrimal glands, and glands of the nose and palate. Cranial nerve 7 provides presynaptic parasympathetic fibers to the pterygopalatine ganglion and submandibular ganglion. Parasympathetic innervation of the lacrimal glands. At the geniculate ganglion, the greater petrosal nerve arises from cranial nerve 7 to enter the middle cranial fossa. It then joins the deep petrosal nerve, sympathetic, and the foramen lacerum to form the nerve of the pterygoid canal, also known as the Vidian nerve. The nerve of the pterygoid canal courses through the pterygoid canal to enter the pterygopalatine fossa, and its parasympathetic fibers synapse in the pterygopalatine ganglion. From the pterygopalatine ganglion, postsynaptic parasympathetic fibers emerges to innervate the lacrimal gland via the lacrimal nerve of cranial nerve V1 and zygomatic branch of cranial nerve V2. Parasympathetic innervation of the submandibular and sublingual glands. The cauda tympani branch emerges from cranial nerve 7 just superior to the stylomastoid foramen, and it then crosses the tympanic cavity medial to the handle of malleus. It subsequently passes through the petrotympanic fissure to join the lingual nerve, which is a cranial nerve V3 branch in the infratemporal fossa. Parasympathetic fibers of the cauda tympani synapse in the submandibular ganglion. Postsynaptic fibers follow arteries to the submandibular and sublingual glands. Taste sensation from the anterior 2/3 of the tongue and palate is transmitted via cranial nerve 7 fibers, which is carried by the cauda tympani that joins the lingual nerve of cranial nerve V3. Somatic sensory supply. Some sensory fibers travel by the facial nerve and geniculate ganglion to reach the trigeminal sensory nuclei and supply the auricle, skin of the auditory canal, and outer surface of the tympanic membrane. Testing of cranial nerve 7. Steps. Both left and right sides are tested simultaneously. The patient may be asked to mirror the examiner's action. Inspect for asymmetry at rest, at the nasolabial folds, angle of the mouth, and the forehead wrinkles. Long-standing cranial nerve 7 palsy can cause fibrous contraction of muscles on the affected side. A more pronounced nasolabial fold can paradoxically occur. Cranial nerve 7 palsy does not cause eyelid ptosis. Then ask the patient to raise their eyebrows. Watch the forehead wrinkles. Press the patient's eyebrows down and note any weakness. Ask the patient to close their eyes tightly. Watch for closure of eyelids. Test against resistance with a finger and thumb and say, "Don't let me pull them apart." Bell's phenomenon. This refers to upward movement of the eyeballs when the eye closes. This can be clearly seen if the eyelid failed to close due to cranial nerve 7 palsy. Ask the patient to blow out their cheeks. Watch for air escaping on one side. Ask the patient to bare their teeth and look for asymmetry. Ask the patient to purse their lips and look for asymmetry. Sensation of the external auditory meatus can be tested by light touch and pinprick. Taste sensation. Use cotton buds dipped in the solution of choice applied to each side of the tongue in turn to test each side separately for sweet, salty, bitter and sour taste. Swill the mouth with distilled water between each taste sensation test. Findings during cranial nerve 7 palsy. For upper motor neuron lesion, unilateral causes includes cerebrovascular accident, etc. There is a loss of facial movement on the ipsilateral side. Forehead wrinkling is preserved as both sides of the forehead receives bilateral nervous supply. For bilateral causes, this includes pseudobulbar palsy and motor neuron disease. For lower motor neuron lesion, there is loss of all movement on the ipsilateral side of the face. Unilateral causes includes demyelination, tumors, Bell's palsy, pontine lesions, cerebellopontine angle lesions, etc. Bilateral causes includes sarcoidosis, GBS, myasthenia gravis, etc. Bilateral cranial nerve 7 palsy will cause a sagging, expressionless face. Ramsay-Hunt syndrome. This refers to unilateral paresis caused by herpes at the geniculate ganglion. Herpes rash may be present on the external ear. Cranial nerve 8, the vestibulocochlear nerve. The vestibulocochlear nerve arises from the brainstem at the junction between the pons and medulla. Location of nerve cell bodies are at the vestibular ganglion and the spiral ganglion for the vestibular nerve and cochlear nerve respectively. The vestibular nuclei is located at the junction of the pons and medulla in the lateral part of the floor of the fourth ventricle. The cochlear nuclei is located in the medulla. Cranial exit for cranial nerve 8 is via the internal acoustic meatus. Course of cranial nerve 8. Cranial nerve 8 emerges from the junction of the pons and medulla. It enters the internal acoustic meatus and separates into the vestibular nerve and the cochlear nerve. The vestibular nerve is composed of the central processes of bipolar neurons in the vestibular ganglion. The peripheral processes of these neurons extend to the maculae of the utricle and saccule, which are sensitive to linear acceleration and pull of gravity relative to the position of the head, and the cristae of the ampullae of the semicircular canals, which are sensitive to rotational acceleration. The vestibular nerve then joins the auditory fibers in the facial canal. The cochlear nerve is composed of the central processes of the bipolar neurons in the spiral ganglion. The peripheral processes of these neurons extend to the organ of Corti in the ear for sense of hearing. Within the internal acoustic meatus, cranial nerve 8 is accompanied by the primary root and intermediate nerve of cranial nerve 7 and the labyrinthine artery. General functional type of fibers for cranial nerve 8 is special sensory, general distribution to the internal ear. Main actions. The vestibular nerve transmits vestibular sensations when head movement occurs, during equilibrium and motion, acceleration or deceleration from the semicircular ducts, utricle and saccule. The cochlear nerve transmits hearing sensation from the spiral organ. Testing of cranial nerve 8. Inquire the patient of hearing loss or balance problems. Inspect the ears for abnormalities. Test each ear separately by covering one by pressing on the triggers or creating white noise by rubbing your fingers together at the external auditory meatus. Hearing. Whisper a number into one ear and ask the patient to repeat it. Repeat with the other ear using a different number. Whisper at the same volume in each ear and at the same distance of about 60 centimeters. The Viii test. To test for air conduction, tap a 512 Hz tuning fork and hold adjacent to the ear. To test for bone conduction, apply the base of the tuning fork to the mastoid process after testing for air conduction. Ask the patient which position sounds louder. Normally air conduction exceeds bone conduction, and this refers to Viii positive. During neural deafness, air conduction is more than bone conduction and Viii is positive. During conductive deafness, Viii is negative and bone conduction is more than air conduction. The Weber test. Tap a 512 Hz tuning fork and hold the base against the vertex or forehead at the midline and ask the patient if it sounds louder on one side. During neural deafness, the tone is heard better in the intact ear. During conductive deafness, the tone is heard better in the affected ear. Vestibular function. The turning test. The patient is asked to stand facing the assessor with arms outstretched. The patient is then asked to march on the spot and then close their eyes while continuing marching. If there is a vestibular lesion, the patient will gradually turn towards the site of the lesion. Hal-Pike's maneuver is to test for benign positional vertigo, BPV. This maneuver is contraindicated in patients with no neck problems or possible posterior circulation impairment or during patient refusal. Warn the patient regarding the procedural steps of this maneuver, warn that they will feel dizzy, and warn that they will not be allowed to fall. Sit the patient on the bed facing away from the edge of the bed such that when they lie back their head will not be supported over the edge. Turn the patient's head 45 degrees to one side and ask them to look in that direction. Lie the patient back quickly, support the patient's head so that it lies about 30 degrees below the horizontal. Maintain the head turned to one side at 45 degrees as the patient is lied down. Hold this position for at least 30 seconds. Watch for nystagmus. The affected ear will be the lowermost. Repeat the procedure with the head turned in the other direction. Findings. There is no nystagmus if it's normal. In BPV, there will be nystagmus with a slight delay of about 10 seconds, and nystagmus is fatigable, can't be repeated successfully for 10 to 15 minutes. If there is central vestibular system pathology, nystagmus will occur with no delay and no fatiguing. These are my references. Thank you.